So first today we'll look at the kaleidoscope of collaborative practice. The future of nursing and healthcare really depends on partnerships. The growing demand for teamwork and collaborative practice is needed in this day and time in healthcare. So, how do we define collaboration? It's the recognition of the expertise of others within and outside one's profession, with some shared functions and a common focus on the same overall mission, which is to take care of the patient and provide optimal health care. Sullivan further defined collaboration as a dynamic, transforming process of creating a power sharing partnership for purposeful attention to needs and problems in order to achieve likely successful outcomes. So, when we look at the roles of the advanced practice nurse, with the Certified Registered Nurse Anesthetist, the CRNA, autonomy varies with states and institutions, and it's been a constant battle with surgery and anesthesiology since the early 1900s. With Certified Nurse Midwife, the origins of that profession in the Appalachian clinics of Kentucky, the interdisciplinary practice is an indispensable element of certified nurse midwife practice, and the need for the clinical nurse specialist, the CNS, originated in the 1930s as a nurse clinician, and collaboration has always been an essential part of the role. It was the first established in psychiatry and not originally concerned with prescriptive authority. The nurse practitioner has met medical opposition related to control and competition in practice. Early opposition from nursing leadership originally moved to graduate level education from certification programs in many medical schools. The acute care NP role forced differentiation of the role, and ultimately authority is shared and referrals are bilateral when we look at collaborative practice for these advanced roles. So, what are some components of collaboration in healthcare? Separate and unique practice spheres, common goals, shared power control, and mutual concerns for the patient. So, listed below are some of the barriers, including social isolation, organizational hierarchy, the unrecognized diversity, role and language confusion, as well as inadequate communication patterns, as well as others. So, how do we build strategies for success for collaboration to create an effective team, accept growth, and develop a joint responsibility? We need to use protocols and guidelines wisely and watch our language to make sure we're inclusive of all disciplines. So, there are some collaborative models that exist, which include the primary nursing model, the differentiated practice model, collaborative practice model in a clinic, and collaboration in long term care. Next, we'll look at the participation of the advanced practice nurse in managed care and quality initiatives. And the reality is that advanced practice nurses have been largely absent from managed care provider panels, and their efforts are not fully recognized in national quality activities. So lately, we've had a transition of healthcare delivery to managed care, and we've had a departure from what we call fee for service into pay for performance. With prospective payment, global pricing, and capitalization are prominent. There's been a shift of risk from insurer to provider, and the focus of development on practice guidelines, prior authorization, utilization review, quality assurance activities, and outcome analysis. The creation of provider panels with a host of practitioners and coordination of service provision among providers. And there's been a renewed emphasis on the bottom line in a very competitive market. So, self insured managed care plans challenge state laws as to who they want to include in their panels. 85% of the population is covered under managed care plans. The majority, about 50% of those, are in commercial plans, and 35% are in Medicare or Medicaid managed plan options. So, as a participant of a provider in a managed care plan, what kind of skills do we need? Clinical accountability, communication skills, leadership skills, team building abilities, negotiation, conflict resolution skills, quality management ability, and looking at the financial outcomes. So, a couple of the national quality efforts due to the Tax Relief and Healthcare Act of 2006, PQRI, which is Physician Quality Reporting Initiative, came about. And then with the National Quality Forum, the NQF voluntary consensus standards were developed, and gaps in healthcare quality research were identified. Other efforts include the National Technology Transfer and Advancement Act of 1995, which gave voluntary consensus standards legal standing. Things such as the Hospital Quality Alliance, the Joint Commission on Nursing Performance Measures, and the American Medical Association Physician Consortium for Performance Improvement. Some examples of patient-centered outcome measures include death among surgical inpatients with treatable serious complications, which was known as failure to rescue, pressure ulcer prevalence, falls with injury, restraints, urinary catheter associated UTIs, central line catheter associated bloodstream infections, and ventilator associated pneumonia. So, next we're going to shift gears and talk about resource management. Um, Obviously, an organization has to produce a product or service of value, otherwise known as output. Being of value, revenue has to be generated, and revenue generated will cover the cost of resources expended, which are called the input, and some level of profit or receipts over disbursement is necessary for continued viability. So usually a matrix structure organizes transactions. On one axis, you aggregate transactions according to type, and on the other, you aggregate them according to the product line, physical location, or activity. And transactions are summarized in a statement of profit and loss or income and expense. Revenue, as monies received for services provided, is based on the price or charge allocated to a specific service, activity, or item, and the charge reflects the related cost of the service plus a margin of profit. And charges are discounted or bundled under a global fee, waived for charitable care, or not collected from those who are expected to pay. And charges are not accurate reflection of income. So, who are the payers of these? Federal government, state government, managed care, private sector, indemnity coverage, and pay for performance systems, which link reimbursement with quality and outcomes. How do you calculate revenue? It's the sum of charges on the financial statement as a gross patient services revenue, and then deductions include contractual allowances with insurance companies for being in network, differences between the charge and the actual payment, and charitable care. Bad debt is not deducted from the revenue, and the net patient service revenue is the GPSR, which is less contractual allowances and charity care. The total operating revenue is the NPSR plus other operating and research revenue, and there may be a non-operating revenue which is not directly tied to services such as interest and gifts or donations to a nonprofit entity. So, what is the expense? It's obviously the cost incurred in providing services or producing products. Wages and benefits are also expenses, non personal supplies, minor equipment, activities, interest on loans, and so on, and depreciation of the assets of the company. And every company must use budgeting um, to translate the organizational plans into quantities and dollars. There are different types of budgeting. For strategic budgeting, there's low range budget that addresses the direction of the organization over 3 to 5 years or more, and it projects the volume and resources at a high level with estimations of revenue and expense totals, but not extremely detailed. It's a major driver of volume, and resources must be described and quantified, and it's a schematic representation of an organization's direction, which is periodically reviewed. The operational budget is detailed and it has the day to day activity of the organization. It includes detail on projected volume and resources, as well as associated revenue and expense, and it's constructed for the fiscal year. It incorporates assumptions that will affect revenue and expense, such as inflation and reimbursement, and is prepared at the detailed level of account within the cost center. It includes actual experience reported against the budget for each accounting cycle and presents each fiscal year's operating budget independent of other years. In the budgeting process, you have to identify what generates revenue and drives resource utilization. You have to look at workload measures that identify both significant activities that generate resource utilization and elements that account for individual variation. And the activity and resource projections are then translated into dollars. Total revenue is volume times price, adjusted for the payer and contractual variations. And there's a movement of implementation with evaluation. So, what are some of the ethical strategies for maximizing revenue? We have to place an emphasis on how much volume and revenue the individual practitioner generates, including incentive programs. When direct billing is not possible, there's a need for other measures of volume and activity, and rather than charges, focus on systems that affect the volume of activity. That's the basis for payment. Inaccurate or incomplete documentation can lead to lost revenue opportunities, and we also have to look at payment denials. Cost containment is another area we have to continue to look at, making sure that we're using supplies and personnel adequately and looking for alternatives in relation to potential impact on other aspects, looking at the marketing forces, regulatory requirements, and ethical management practices. Another way of cost containment is happy employees, because dissatisfaction and turnover generate additional costs for a company, as well as standardizing supplies and negotiating the primary method of containment, figuring out who we can get our supplies from the cheapest. And cost effectiveness incorporates an element of quality that is not inherent in cost efficiency. Chapter 12 goes back to talking about core competencies of the advanced practice nurse and looking at models of collaboration. So, some on the slide below are some of the core competencies of the advanced practice nurse, one of which is collaboration. And what is collaboration again? It means to work together, especially in a joint intellectual effort. And the inclusion of a team in ethical decision making is key to the holistic care of patients. When we talk about collaboration, quality patient care is achieved by including contributions of all care providers, and the key to success for any initiative that extends beyond an individual's scope of activity. True collaborative practice has no hierarchy, and the common goal is to take care of the patient to provide optimal health. Models of collaboration include the parallel model, the sequential model, shared or collaborative model, and each is distinguished by how is the expertise of each member of the team used to the fullest and who is responsible for decision making and patient care. So, parts of our collaborative process include consultation, expanding the advanced practice nurse ability to work with and through others while maintaining autonomy over the situation, co management, which is working together to manage a complex case with shared responsibility, or referral by relinquishing care temporarily or permanently, like when we refer to a specialist. Interdisciplinary teams are the epitome of working with and through others while recognizing the importance of the individual's clinical expertise. There's a strong emphasis on relationship centered care, and all members of the team work together to create a plan of care together centered around the patient's needs. When you look at a multidisciplinary versus an interdisciplinary approach to patient care, you find in multidisciplinary that there's a non interactive, non intersecting activity. We're all taking care of the patients but in our own silo. Versus in interdisciplinary, you have the healthcare providers integrating together to focus on the patient needs. So, Chapter 13 included a little review of what evidence based practice is, looking at the best clinical evidence and making decisions about the care of individual patients. And we're integrating individual clinical expertise with the best available external clinical evidence from systematic research to provide the best patient care. The slides regarding evidence based practice pretty well speak for themselves and are a review from research, so just review these slides. Next, we'll talk about culture and practice. So, when we look at culture or cultural diversity, it's defined as the integrated lifestyle, the learned and shared beliefs, values, worldviews, knowledge, artifacts, rules, and symbols that guide behavior of a particular group of people. Culture is transmitted intergenerationally. It explains the patterns of thought and action, and it contributes to the group's social and physical survival. Culture is continuous, cumulative, and progressive. And Leininger's sunrise model is one of the theorists that's based on cultural care, diversity, and universality. So, culture is an important part of our practice in taking care of patients. How does Leininger's theory relate to the role of the advanced practice nurse? Um, Respect, advocacy, and partnership. As advanced practice nurses, we have to respect the patient's beliefs, values, and attitudes toward healthcare and their welfare. We have to advocate on behalf of the client based on their personal conception of the world, and we have to partner with the client to guarantee appropriate delivery of care that is culturally congruent for that patient. We must not only look at the cultures, but being culturally competent. And a culturally competent advanced practice nurse is knowledgeable and respectful of diverse cultural beliefs and practices, and partners with the patient to develop care for their health outcomes that are culturally appropriate for that patient. So, how do we move toward cultural competence? First, we have to assess, we have to look at our own personal beliefs, personal biases, values, and beliefs. Second, we have to acquire knowledge to find out what current practice guidelines are and acceptable treatment within designated cultures. Lastly, communication is vital for cultural competence. We have to make sure that our assessment, education, counseling, and documentation all provide communication between the provider and patient that are culturally competent to develop patient trust and be able to communicate with our patients to provide optimal health care. These are some cultural specific websites if you're interested in obtaining further information.